Moving on with the next program, the title is Practical Approach to Mimics of Malignancy, and the first contributor is Dr. Luba from Medical College of Wisconsin in Milwaukee, who is a specialist in thoracic imaging. So thank you very much, and on you go, Luba.
Thank you. I hope everybody can see my screen. I just start sharing the screen. Just let me know if everything is fine, and you can hear and see me as. But it somehow does not. Just a moment, because I'm trying to. Okay, it should be fine. So. First of all, I wanted to thank everyone thank for the invitation, and I'm really happy to speak at our virtual conference this year. I do hope that next year we'll be able to meet each other and we can see each other finally in London. My topic is mimics of malignancy, lung and pleura, and quite frankly, I'm very excited about that topic. In general, I love the spin on the pathology and diseases, but also while preparing this, I found out that there's so much to tell that there's no way I can put it in one lecture. I will try my hardest, but here we go. So we'll try to review the spectrum of lung diseases, of course, not all of them, but the diseases that can potentially mimic lung malignancy or lung cancer. We'll review some examples of benign pleural conditions as well, with appearances that can resemble pleural malignancy. And we'll also discuss some key findings that hopefully will allow you to suspect benign lesions and manage them that way, the lesions that can mimic malignant tumors in the thorax and the lung and pleura. And I have no financial disclosures to report. So benign conditions that mimic thoracic malignancy, as you see, there are a lot, and there's a huge list, and this list is not complete. Most common diseases are infectious, inflammatory, and granulomatous diseases. And just to name a few, those would be tuberculosis, number one and only. Blastomycosis is coming second. Coccidioidomycosis, crypto, Aspergillosis, mucormycosis, Actinomycosis, sarcoid, amyloidosis, etc. I will try to show most of these diseases that are there's subtypes that are pertinent to the topic. Benign and atypical neoplasms include hamartoma, histoplasmoma, endometriosis, and I'll show you thoracic endometriosis case as well, atypical adenomatous hyperplasia or AH, thoracic splenosis, organizing pneumonia, solitary fibrous tumor as well. I did include vascular and hereditary diseases here too. There are not that many, but pulmonary AVM and HHT, as well as pulmonary sequestration, I believe should be covered in that topic because they do look like malignancy sometimes. So let's start with the pulmonary tuberculosis. As we all know, pulmonary tuberculosis comes in many phases, but one of them actually is looking like malignancy. This is a case of 61-year-old patient who had a hepatitis C and pulmonary tuberculosis. When we're looking at the CT images in lung window and the coronal reformatted images and the axial to axial slices here, it does sure look like a mass with spiculated borders and maybe partially obstructing bronchi of the right upper lobe, as well as we see on the coronal reformatted image here. Looking a little bit lower down, looks like that there's some cavitary component to it. And in addition, there are also not only speculations, but a lot of satellite nodularity. And that does not mean that satellite nodularity automatically will tell us that this is an infectious etiology, because we can see it in tumors as well, but maybe just a second thought on the back of your mind to think about infection as well. This particular patient actually did go through entire workup, including biopsy. The biopsy was taken because this really looked like a large speculated mass in the right lung. And as you can see, we received we're talking about tuberculosis. This was a biopsy proving tuberculosis. Patient started on treatment. Unfortunately, after treatment or during treatment, and probably because of his background of hepatitis C as well, he developed, excuse me, acute liver failure and did not survive. So here on the two images on the right, we're seeing, again, mass-like appearance of a tuberculosis here in the right lung. But in addition, we're seeing more of a ground glass opacity. We're seeing bilateral pleural effusion. That is when he developed a liver failure, respiratory failure, and unfortunately died. So tuberculosis is actually one of the most common mimics of lung cancer, particularly its atypical form. It is FDG avid, and that's what happened with our patient as well. So it is really difficult to tell if we're talking about inflammatory or infectious, excuse me, infectious disease, because as you saw, that can really be as a large mass-like opacity. It can also present as nodules or masses. Do you think about endemic areas, poor socioeconomic status, exposure or contact with someone who has tuberculosis? Sputum cultures, history, bronchoscopy, and biopsy, CT, PET CT, all this comes into consideration when we're making this diagnosis of tuberculosis as opposite to a lung cancer. And the final diagnosis is done by cultures and histology. And even though the outcome was not favorable, we did everything we needed to diagnose the disease. So the second disease that I put actually here is blastomycosis. It's a fascinating disease caused by blastomyces dermatitis, excuse me, which is broad-based body yeast. And it is not only seen in United States, more common southeastern and central United States, Ohio Valley, along the Mississippi River, Great Lakes, but also seen in Canada, also seen in Africa, also seen in Middle East, India. So that's not just relevant to US population or Canada, but also seen in other parts of the world. The blastocysts in soil, especially in wooded areas, and spread by inhalation or skin inoculation. So here's an example of acute infection by blastomycosis. The acute infection often symptomatic and can present as pneumonia. That's the example as we have this in this particular case. So this patient came to us with acutely ill with a large consolidation here in the left upper lobe lingula, and it looked like that it had obstructive component and post-obstructive pneumonia as well. They had another focus here along the pleura, and then here in the soft tissue window, as you can see, it really looks like obstructing mass and maybe post-obstructive pneumonia as well. On top of it, actually, when we're looking at the lower slices here, axial and coronal reformatted images, there is some additional nodularity in both lungs that is seen in bilateral lower lobes and also seen in the upper lobes as well. So this is an acute presentation of blastomycosis. Chronic infection may resemble post-primary tuberculosis. They can also be disseminated disease into skin, bones, and GI tract as well. So what is the most common presentation of blastomycosis? Most common is focal or diffuse consolidation. Focal disease may be seen as a mass and may be mistaken for cancer, as as in this particular case. There can be also multiple or solid, just as solitary nodules as well. So this patient underwent treatment, and I'm just showing you a gradual improvement compared to this particular, compared to this very first imaging, these slices, and then gradual improvement with some residual pleural-based, ill-defined, solid pulmonary nodules. When this lesion, the dominant lesion that we saw at the beginning, almost gone away, and then gone away completely or almost completely on the subsequent examinations. So this next case that I want to show you is also brings important point, because this patient had sarcoidosis, and this patient had sarcoidosis for many years and has been treated for sarcoid. So what happens with these patients, that they're long-term on corticosteroid treatment, they're on immunosuppressed, and they develop superimposed infection, and particularly reported blastomycosis on top of the sarcoidosis. So this is the beginning. This is initial examination. Is a sarcoid looks like a mass. So there's a solid component. The lesion definitely looks spiculated and very ugly. When we're looking at the additional slices, we do see that there's a abutment and potential going through or over the fissure. There's also a nodularity, a satellite nodularity around this dominant mass-like lesion. But there's also left lower lobe, some subtle nodularity. We could talk about tree and bud nodularity, but there's also some solid and randomly distributed nodules. There also a parabronchovascular and paralymphatic nodularity. So this is a case of sarcoidosis, which 9 years later looked like that. So patient is on treatment and looks very classic. So mid and lower lung, mostly mid lung predominant. Here's the dominant mass-like lesion. That's how it looks. It's still speculated, it still looks bad, but it did not increase in size, even slightly gotten smaller. And we have much more clear nodularity here in the other lobes bilaterally. And this is a classic case of sarcoidosis. However, 6 years later after that, we're starting seeing something different. We're starting seeing additional mass-like, ill-defined, scattered, randomly distributed nodules, but also in mass-like opacities as well. And that's when this patient was diagnosed with a blastomycosis in sputum as well. So what would be the differential diagnosis when we're looking at something like this? If we did not know that this is sarcoidosis, we would think about histo, we'd think about blasto, we'd think about MAC, we'd think about cryptococcus as well. And never to forget Aspergillosis and formation of mycotomas. So going to the next infection or next fungal infection is Coccidioidomycosis. So this is also important entity to recognize and remember when we're looking to differentiate between the cancer or not cancer. So caused by Coccidioides immitis, thick-walled spherules, as you see, southwestern United States in the desert regions. It's also called the valley fever as well. It is very severe disease when it is disseminated. So, but it also has specific different forms. So most of the patients would be asymptomatic. Some of the patients would develop solitary or coccidioidoma. They can develop multiple nodules, and that would can develop within weeks or months. So disease is really unpredictable to a certain extent. It does tend to cavitate with thin or thick walls, and it can have a chronic granulomatous inflammation and fungal spores. It can be stable, it can resolve or grow, and that is a particular challenge for us to recognize if we're talking about infection, or we're talking about fungus, or we're talking about malignancy. As here in this particular example, there is a peripheral, ill demarcated or even speculated solid nodule without calcifications. And this was biopsy-proven coccidioidomycosis in 42-year-old male. The background of this, or past medical history of this patient, need to be mentioned as well. He had alcoholic cirrhosis, esophageal varices, and rheumatoid arthritis, and tobacco dependence, and he was immunosuppressed, chronically immunosuppressed. I did want to show additional slides here with this satellite nodularity with multiple nodular densities in the caudal aspect of that lesion, just to make sure that that you're looking for it. And then also this cavitary lesion, even though in the literature the description is thin wall or thick wall, in this particular case we had a thick wall cavitary lesion and multiple additional nodules in the lung parenchyma. This is an additional case of blastomycosis, but this is a disseminated type of blastomycosis and acute disease. So on the right here, on my right, you can see that these are sort of mass-like opacities, and they're ill-defined, and they look like maybe a lobar or segmental consolidations. But on the CT, that's a different patient is 52 years old with HIV. This is a case of diffuse or disseminated blastomycosis as well, and it can resemble lymphangitic spread. It can resemble metastatic disease as well. So we really need to make sure that we remember about that disease. So next case or next infection that I want to discuss with you is actinomycosis. So this particular case also presented a challenge, a diagnostic challenge in our practice. And this patient actually went through full workup and finally had to go through lobectomy as a final treatment. So what we're seeing here is a 72-year-old female. She had asthma, chronic sinusitis, and she came with cough, dyspnea, and weight loss. So she had her IV antibiotics and she did not improve. So these are just reformatted or reconstructed images, coronal and sagittal, with contrast and without contrast. And the reason I'm showing it to you to show this broncholymph that abstracting the bronchus and creating this post-obstructive atelectasis and pneumonia. And what happens? What happens is that it resembles malignancy because it does not improve with antibiotics. CT scan was read as right lower lobe mass and highly concerning for malignancy. We did a PET CT and we did see FDG uptake and again suspicious for malignancy. Bronchoscopy was done and bronchoscopy detected the lesion in the right lower lobe, the lesion that has been removed with a lot of pus going out of the bronchus after removal. So, and finally on pathology, actually the final pathology was actinomycosis. So this is a case of actinomycosis with obstructing broncholymph. So this patient still did not improve and had to go for lobectomy, as I mentioned, as a final treatment. So what does pulmonary actinomycosis do and how does it look? Chronic segmental airspace consolidation containing necrotic areas of low attenuation with frequent cavity formation, and that is because of the obstruction. There is a lot of mucus. There's a lot of mucus accumulated within the dilated bronchi. There are areas of necrosis, areas of infection, and growth of actinomyces there, and that is why it may mimic a mass. Cavitation, bronchiectasis, lymphadenopathy, and pleural effusions are common. And if you think about it, all these we can also see in malignancy. So it can also extend through adjacent pulmonary lobe and invade the pleura as well. And if there's a bronchiolithiasis and chronic post-obstructive pneumonia, then the diagnosis should be almost always suspected in the bronchial actinomycosis, especially if a patient is located in endemic areas, or like for tuberculosis or histoplasmosis. Next condition is a very rare condition that I wanted to talk to you about, and this condition is solitary histoplasmoma. I'm not going to talk about all possible fungi and atypical infection. We unfortunately don't have time for this, but this particular one is very rare. And if we don't look for it, if we're not really assessing the specific appearance of calcification within this solitary lesion, then this might be also misdiagnosed as a malignancy. So caused by Histoplasma capsulatum, it is solitary nodule in the lung, and it's very unusual that histoplasmosis is just a single solitary nodule, and not necessarily always calcified. It can be non-calcified and then presents even more diagnostic challenge. It's called isolated coin lesion, and the calcium deposits in the concentric rings out of the center, around the center of that lesion. And when we see something like this, especially there's also a small calcified lymph node here in the hilum, the diagnosis is almost always a solitary histoplasmoma. So I do have to mention opportunistic fungi in Aspergillosis would come first in the consideration here, but there are many: Aspergillus, Candida, Cryptococcus, Mucormycosis. They're worldwide distribution in immunocompromised hosts. And the problem is that sputum cultures are not always reliable. And we've seen multiple cases in many patients who had to go through extensive workup to make sure that they don't have malignancy. So just to recap, just a really one slide to show you, because I'm sure everybody is familiar with the Aspergillosis. We're talking about invasive and semi-invasive Aspergillosis in immunocompromised patients, and non-invasive Aspergillosis in chronic or immunocompetent patients. And the hallmark or specific signs that we're looking for are halo sign in invasive and semi-invasive Aspergillosis that indicates that the area of necrosis and invasion and hemorrhage around the lesion, and most of those nodules, 50% of those nodules are going to cavitate because they're going to evolve. The necrosis is going to evolve as well, and we're looking for air crescent sign that also indicates presence of necrosis as well. So talking about non-invasive Aspergillosis, here's an example of the thick-walled irregular cavity in the left lower lobe on the chest radiograph, and then left lower lobe here posteriorly, budding the posterior pleura on the CT image right here. It has this fungus ball within it as well, and most likely to represent is Aspergillosis. The problem with this particular case, though, we expect these lesions to be in the upper lungs. In apices, this particular one is in the lower lung. So we do not forget that that's how necrotic or aggressive neoplasm can look as well. So a cavitary cancerous cavitary neoplasms can look like this, especially when the location is atypical. So next entity that I wanted to talk about is pulmonary amyloidosis, and this entity is really rare, but we do come across, and it almost always presents the challenge. And the challenge is because there's different types of pulmonary amyloidosis. Could be primary pulmonary amyloidosis or secondary amyloidosis. It could be nodular or nodular cystic pulmonary form, as in this particular case. So this there are multiple lesions that are in the lung parenchyma, but also involvement of the pleura as well. And you can see that those cavitary lesions they have fluid within them and significant air component as well. There's a pleural involvement and near circumferential pleural involvement here. So there are lesions that are not cavitary, that they're solid, and they do not show calcifications as well. So we have multiple lesions in both lungs. We have near circumferential thickening, nodular thickening of the pleura here. And we have mass-like and cavitary lesions as well. So this particular case is very worrisome for malignancy, because that's how we can see metastatic malignancy. That's how mesothelioma can look like that as well. So what we're looking for calcification. I do have a few slides, but we started late, right? What time did we start? Yeah, so how much time do we have though? 2 or 3 minutes left. Oh, right. So no, that I do have quite a few more slides, but I'll go fast. So another consideration is around atelectasis. Also, as probably all of you know, around atelectasis also presents a challenge, diagnostic challenge. We're looking for adherence to pleura. We're looking for prior trauma. We're looking for the comet tail right here, and that has and we're looking for stability, lack of growth, and a lack of uptake. FDG uptake on PET CTs. Most of those patients actually do get PET CTs and biopsies to make sure that this is not a malignancy. Next entity is a focal organizing pneumonia. This is a 61-year-old female with renal cancer. She has a very large RCC in the left kidney. So in addition to this is her CT, chest CTs. We're looking at the peripherally distributed, very classic appearing organizing pneumonia, but in the left lower lobe, it looks more of a mass-like. And having patient with a large renal cancer, it really is difficult to just let go just based on the appearance. So PET CT was positive. These lesions are FDG avid. This patient had biopsy done and confirmed as a focal organizing pneumonia. So this is another case of a parenchymal amyloidosis. Just to show really quickly, this is a nodular parenchymal amyloidosis, as a few scattered nodules that can look like malignancy with speculated and irregular contours with the calcifications within them and calcified lymph nodes as well. So endobronchial hamartoma is a rare entity. However, this particular case, we were able to measure attenuation of this lesion that sits within the bronchus and partially obstructing the bronchus. As you can see, minus 91 Hounsfield units. This is a macroscopic fat. It was diagnosed and resected. So I have to touch on atypical adenomatous hyperplasia as well. We often see those ground glass nodules that are there for many years. We do need to monitor them up to 5 years at least, and these are considered pre-invasive lesions per WHO. They're small proliferative lesions comprised of single-layered atypical cells, and they're possibly precursors of adenocarcinoma. So a couple of those cases that are hereditary or genetic. And this is the lesion in the left lower lobe, as you can see here on the lung window, in the soft tissue window, that turned out to be pulmonary sequestration. This is intralobar pulmonary sequestration, and the small artery, a feeding artery, actually arising from the distal descending thoracic aorta. Here's another one on the right side. Most of the sequestrations we will see in the left. This one is on the right side, and here that can look like irregular and speculated mass. Here, this is a draining vein and other vessels that are connected to the sequestration, and the PET CT, of course, does not show any avidity. So I do have just a couple more slides left, not too many. The pulmonary AVM and HHT, hereditary hemorrhagic telangiectasia, genetic disorder. Here's the example of multiple small AVMs, and this is maximum intensity projection reformatted image right here to show this small AVM. This patient had brain findings as well, and had to have multiple embolizations of those AVMs. The risks are rupture, bleed, pulmonary arterial hypertension, a significant shunting, fatal embolism, strokes, etc., etc. So we do need to recognize them. We don't want to biopsy them as well. So another entity is pleural endometriosis or catamenial pneumothorax, very rare entity. We did have the patient that I wanted to show you. It really looks like pneumothorax here, but there really looks like soft tissue density seeding, those nodules seeding the pleura. There's also pleural effusion. And the patient is 40 years old, relatively healthy. She came with pain. She did have a history of pelvic endometriosis, and the consequences of those are usually pneumothoraces, hemothoraces, hemoptysis, and lung nodules. So these ones as well, you probably don't want to biopsy. This is very characteristic appearance. So in other entities, thoracic splenosis, and it does look like solid, non-calcified nodules that can be seen along the pleural surfaces and in the parenchyma as well, and in the diaphragm as well. So what we're looking for splenectomy, we're looking for a history of prior trauma, and we're looking for no spleen or fractions of spleen or abnormal appearance of the spleen. The reason I'm showing you this because here's another case that looks very similar, almost identical, with those nodules sitting along the pleura and diaphragm. But we do see the spleen here, and PET CT was showed FDG avidity. This was a case of mesothelioma. Solitary fibrous tumor is one of those tumors that need to be recognized. It is mesenchymal tumor, can be anywhere, mostly asymptomatic, incidentally discovered. But on CT with contrast, as you can see, it looks heterogeneous with areas of necrosis and enhancement, and on MR, it heterogeneous and large areas of bright signal. And I apologize for running that fast, but these are the entities I wanted to cover. And I hope that you learned something from this, and I'm more than happy to answer any questions